Hi, folks, happy Friday. Welcome to RLR VMR. We're very, very excited to have you. Um, Before I pass the mic to Prof. Raz, let me introduce everybody who's here making this happen, beginning with Jillian, who is doing scribing yet again 2 days in a row. Mic to you, Jillian.
Hi, everybody. Excited to scribe today for the Robbie and Reza discussion. Lucky to be here, excited to learn.
We're lucky to have you, my friend. And Gerardo, you're on teaching point today. Mic to you.
Yes, hello everyone. I'm doing teaching points today, and I'm very excited for the Hans case and the discussion from Ravi and Reza.
Thank you, Gerardo. A Hans case indeed. Maybe Hans, we can hand the mic to you to say hello.
Hello to everybody, and I'm just on my break in a little clinic, and I'm happy to present a case. It will not take too long of your time, I think. And whenever you're ready, I'll start with the chief complaint.
Hans, I just want to say I've been a huge fan of yours, like for so long. You're always so active in the chat, and it's terrific to finally get the opportunity to discuss one of your cases. So thank you for, being so present for so long.
No, it's my pleasure, and I've learned so much on this platform that if it no longer existed, I would miss it very much. It's really an excellent place with friendship and learning, which I don't want to miss anymore. So let's start with the chief complaint. And we have for today a 12-year-old boy who presents with progressive bilateral arm pain and notable weakness and numbness in both arms. And this has been going on for 2 weeks. And I'll stop here with the remark, it's not a pediatric case. It fits into our internal medicine very well.
You're too kind. Because I was about to say, like, definitely feeling the nerves. Once I saw the 1 and the 2, I'm like, I shouldn't be the one discussing this case. Maybe I can. So I think it's actually really helpful that you mentioned that, Han. So we'll just tackle this like we would a patient of any age. And it's interesting when you get this chief concern of arm pain, weakness, and numbness. In general, something about weakness is your job is to determine if there's true decrease in muscle power. When you have objective weakness, it sometimes is quite challenging to distinguish true weakness from the sensation of weakness. Like Hans, last night I didn't sleep too well, and I'm feeling tired. I have this large cup of coffee. I'm about to get a text from Rob asking me if I'm doing okay because I'm not that usual energetic self. But another challenge in this case in determining true versus the sensation of weakness is pain. Like if you have ever examined someone with a lot of pain, it's very difficult to assess their muscle strength. But there's one clue that really points to true muscle weakness and makes us put our neurology hat on, and that's the numbness. That numbness is making me frame this as a localization times tempo neurologic problem. And maybe I can start with the localization, and then Robbie, if you can like incorporate the tempo to help us make progress in this problem. When you're doing localization in a neurologic problem, it really comes down to, is it the central nervous system or the peripheral nervous system? And what's going to be really helpful to make progress on that is looking at stuff like the reflexes. Like reflexes are super, super helpful. If they're really brisk or if they're absent, they can be quite telling. Now, there is just one caveat with that. In someone with an acute spinal cord process, they may initially have absent reflexes, but then later become hyperreflexic. And then the other stuff you look for is spasticity, fasciculations, and if it's been going on for a long time, if there's any muscle atrophy or not. And when we approach this problem, if you think about it, if we were saying, is this central nervous system or the peripheral nervous system? The truth is, it can be a good fit for both. And I'll tell you why, because the fact that it's symmetric could mean that you're having something central, and it would be a nice fit for something happening in the spinal cord. Though if it is something central causing bilateral numbness and weakness, you would also expect a sensory level and problems that are probably occurring further south than just the arms. The Rabih, we see a lot of patients with like cervical spinal disease that can develop exactly this picture, right? As far as the peripheral nerve, it could be a really good fit for that as well. But it wouldn't be a fit for the classic ascending polyneuropathy, because already we're saying it's in the hands and it's not in the legs. So if I'm prioritizing the peripheral nervous system, this is before the exam, I'm going to move away from the classic, axonal polyneuropathy and more prioritize a demyelinating condition. I'm going to leave it at that, but I just want everyone to know that like the first step in this exercise is really trying to localize the lesion, and the symmetric nature, if it were an adult, would be a good fit for both central and peripheral. But the exam and other features are going to help us make progress. Like if there's bowel or bladder symptoms, putting us more towards central. If there's hyperreflexia, more towards central. If there's no bowel or bladder symptoms, no sensory level, and no hyperreflexia, maybe a little bit of absent reflexes, more towards the peripheral nervous system. But would love to hear from Rabih with regard to the tempo and anything else he wants to add.
Yeah, no, Prof. Rez, I think that I don't have anything else to add about what you just did. And in terms of the tempo, I think that you could in one way, you could realize that the tempo of subacute 2 weeks is actually very complicated. And if you're trying to make an exhaustive list of all the things that can do that, you realize it's a very long one. So my advice is whenever you realize there's a long list, ask yourself, well, instead of regurgitating a long list, can you just make progress on the things that are less likely? And so I think there are two common mechanisms in neurology. The first is vascular diseases like stroke, and the second is degenerative diseases like dementia. And I think those two very common mechanisms are unlikely to explain a syndrome that is not abrupt, i.e. non-vascular, or that is non-chronic, i.e. Not neurodegenerative. I think every other mechanism, Prof. Rez, is metabolic, infectious, post-infectious, demyelinating, structural. So I think the time course here is intriguing because it's not compatible with the two most common time courses in neurology, which is either hyperacute, code stroke, or chronic neuropathy, dementia, so on and so forth. So I think the list of possibilities with the time course is overwhelmingly long, but it's unlikely to be the things that we see bread and butter, unless, of course, that this time course is not accurate, that it actually is abrupt in onset and then hasn't gotten better for 2 weeks, or a close examination reveals things, as you already alluded to, like atrophy, that would imply that the problem has been chronic, but the patient is only noticed for 2 weeks. All right, Mike, to you, Hans.
Yes, then I continue with the history of present illness. And there we have, approximately 2 weeks ago, the boy, he's 12 years old, he fell off his bicycle and landed on his right arm. And I have to admit, it happened to me twice too, when the front wheel got stuck in rails. He denies hitting his head on the ground. He has no head trauma, this he denied right away. He has no loss of consciousness. And he describes the feeling in both arms as a kind of fuzziness. Since his fall, the accident, the pain in the right arm has become worse, as prescribed in the chief complaint. The pain extends to his back and into his left arm. The pain does not radiate anywhere else. And last night, the boy for the first time woke up with pain, and he noticed that he could no longer grasp objects. It was then when his mother decided to bring him in to the ED. In the review of systems, it was found that the boy also has trouble with voiding his bladder, and this he admitted he noticed yesterday. He denies confusion, dizziness, headaches, nausea, and vomiting. His mother gave him Tylenol and ibuprofen, but there was no relief from the pain. The past medical history, family history, and social history, that's all unremarkable. And that does it for the Southwest Corner in one sentence. Thank you very much.
Thank you, Hans. I think, Professor, maybe I can reflect on the finding of trauma, and I'll leave everything else, some of which you predicted, for you to analyze. And I think it's very, very tempting to want to connect this syndrome to the trauma because it is a very elegant fit. But you have to be very careful about the very, very real possibility that when somebody is experiencing something very serious, that they do a little bit of a search in their brain and they try to think of, oh gosh, like what could have done this? And what there is a artificial quest in all of us to tightly associate two things simply because it's possible. And so I think that the mistake to make here would be that the trauma is causing the syndrome 100%. I think the trauma could be truly coincidental and there's a recall bias to bring back this trauma, or the trauma could be contributory, meaning that most people who fall off their bicycle and land on their right arm do not develop a syndrome of this nature that is sneaky and indolent. And I think from the get-go, acknowledging that trauma could, in some very kind of crazy ways, cause this 100% by itself. It also could be truly completely coincidental, driven by the patient's desire to have some sort of story that cohesive, that makes sense in his mind. But it's also, especially, I would say, important not to overlook some intrinsic vulnerability that the patient has. So this comes up quite a bit in adult medicine. So if somebody falls and breaks their hip, well, often, if you fall and break your hip, you might have had a very serious trauma, but you might also have had a pathological fracture or osteoporosis. And so in him, I think we should proceed forward with all three of those possibilities. The most actionable one is in the middle, to not assume that there isn't some intrinsic vulnerability that the patient could have had predisposing them to their fall. But there's a lot else here, Prof. Reza, and I'll hand the mic to you to study.
I think that's so eloquently said. The recall bias, and we might look back at this case and be like, that fall from the bike, although initially we were all like, oh, that sucks. And Hans, it's happened to me in San Francisco where my wheel got caught in the rail and I did a flip, off my bike. And then I got up real quick because I felt like people would judge me for falling. And I was so young and stupid. And I was embarrassed that I was being judged rather than concerned I may have fractured a couple of bones during that fall. But the fall may have been really helpful because it brought this patient to clinical attention. And I agree with Rabih. This is like what this patient is experiencing is beyond the level of trauma they sustained. And so really, I think there might be some vulnerability that got tipped over with the trauma that occurred. I think we're back, Rabih, to the exercise we were doing in the beginning of this aliquot, which is, should we be running towards the central nervous system with imaging, or should we be investing our time and efforts in the peripheral nervous system? The one thing that's really helpful is if you start breaking each of these categories anatomically. So when we talk about the peripheral nervous system as it applies to contraction of a muscle unit, we're really talking about the lower motor neuron, which contains the peripheral nerve, the junction in the muscle. And the reason I'm saying that, Ravi, is because if you just had an isolated muscle problem, you shouldn't have numbness. If you had an isolated junction problem, like myasthenia, you shouldn't have numbness. So really the question, even from the first aliquot, wasn't so much, is it the peripheral or the central? It's really, is it the peripheral nerve, or are we dealing with the spinal cord? And the fact that we have so far, we don't have any symptoms involving the cranial nerves, and we just have these arms, we're in that cervical spine. So it really comes down to a much more specific question. Is it the cervical spine pathology, or is it the nerves that are leaving the cervical spine? And I think the bladder symptoms here is what really helps make the case that you're dealing with a cervical spine pathology. Like Aaron Berkowitz has hammered this home in so many of us that like Guillain-Barré really shouldn't present with any bladder symptoms. Now, you could be in that junction of the cauda equina, which is like in between the central and peripheral, where you can have absent reflexes and bowel bladder symptoms, but we're way up in the cord. So for me, if this were an adult, I'd be like, oh, could he just have BPH? So I wouldn't dismiss it. I think the finding of bladder symptoms with upper symmetric arm weakness and numbness has me rushing to do spinal imaging. Of course, we're going to do a quick physical exam. And what we need to consider here is the age of the patient and not exposing them to radiation. If possible, I would try to avoid a CT scan and go straight for an MRI of the minimum cervical spine, but I would just take it all the way down with the bowel and bladder symptoms just to make sure there isn't something else going on. I'll pass the mic to you, but I do wonder with pediatric cases, like the possibility of some kind of genetic pathology that may have existed for some time, and then again, just got tipped over by a potential traumatic event. Anything to add, Robbie, before we give the mic back to
Nada, Prof. Rez. Nada. Just have another sip of coffee while
dude,
we
I'm
wait.
so tired, man.
How are
Cindy
you?
woke
I'm
me up at
sorry.
4. It was tough, man.
What kind of coffee do you have?
Oh, I went with Dunkin' today with
Nice.
a splash of skim milk. It's really tasty.
Wait, you just have like black coffee with a little bit of skim milk, or did you get
Yeah, I always just drink usually black coffee, but
Ah.
Dunkin's coffee's quality is not good enough to just go straight black. So
the Prof has an anti-sponsor mood. Okay.
yeah, the other day I went to La Pang Quotidienne, and I was just thinking how your mom wanted me to interpret the French imaging. I can't even pronounce the restaurant. But I just added almond milk, a splash, and they charged me $1 for that.
Whoa.
I should have been like, hey, I don't want it. Just give me the 2% that's free. Like, why would I pay $1 for 2 drops of milk?
That's amazing.
But then I took it out of their tip.
You're so cruel. Prof Rez, I have a question for you from the chat. Austin is asking, how was the coffee at the Ritz?
I don't know, Austin. You have to ask Ravi, who experienced it. The coffee actually was delicious. It was so good.
For those of you who have no idea what we're talking about, you have to subscribe to rlrcpsolvers.com. But Hans, please stop us from getting completely derailed. Mic to you, my friend. I'm on my work computer, so I am struggling to find Hans here. Have we lost Hans? Is he still around? Uh-oh. Let me see. Yeah, I think we might have lost Hans. Prof Rez, do you see him? I don't think I do.
He's not listed in the participants anymore.
Yeah, right. Uh-oh. All right, let's see if he messaged us on WhatsApp. We can find him there. Nada. Okay. Let me message him, make sure he's okay.
I'm reading the chat now, Robbie, as we're going to wait for Hans to come back. Wow. Okay.
This is unreal. Okay. Yeah, I wonder if we lost him. Here, let me pause the recording so folks aren't subjected to this on YouTube. You're welcome.
Should we record? Finally, if you're still watching on YouTube, I forced Robbie to hit re-record so that you guys can suffer as we wait to get our presenter back online.
Yeah,
And what we're doing is we're talking about coffee right now. If anyone has any questions about coffee or acai, put them in the chat.
Hans is back.
Oh, he's
That's
back.
why I hit record. Don't flatter yourself. YouTube, this is for you. Insult Prof. Rez. No, Prof. Rez. I hit record well before he came back, but he just got back.
Yeah, I have trouble with the internet here. I missed a little bit of the discussion, but I can continue whenever you're ready.
Oh, don't worry, Hans. Prof. Rez was just inflicting suffering upon those on YouTube, but we did nothing else. All right, Mike, to you for the exam.
Yes, the physical exam, starting with the vitals. We have a heart rate of 76, a blood pressure of 143 over 102, which is unusual for children, is a bit too high. A respirational rate of 15, a temperature of 36.4, which is 97.5 Fahrenheit. General, the patient appears anxious and in distress. He holds his neck in a flexed position. And then we did an extensive musculoskeletal and neurological exam. There was tenderness through T2 to T10, no pain over the acromial joint where he has fallen. And then the neuro exam. The cranial nerves were within normal limit, but then decreased upper extremity strength bilaterally. The deltoid right was 0 over 5, left was 2 over 5, biceps 0 over 5, right 3 over 5, triceps 0 over 5, on the right again, and the left 3 over 5. Grip strength was only 2 over 5 on the right. There was no loss of temperature or other sensation bilaterally in upper extremities.
Well, maybe I'll just comment on, thanks for being back, Hans. Maybe I'll just comment on the vital
I have the lower extremities too, if you want.
Oh, please, so sorry about that, yes.
So we have normal strength and reflexes in both lower extremities, and he can walk without assistance, a normal gait, and has no difficulty in raising himself from a lying position to a standing position. And his post-void residual was found to be 1 liter. And at this point, I'll stop.
Thank you so much, Hans. I'll just focus on the vital signs and give the mic to Robbie to dissect the rest of the physical exam. Yeah, thanks for letting us know about the blood pressure, and that is quite high, and I think it is consistent with a patient in pain and anxiety. So I wouldn't look too much into it. I wouldn't be like, I have to control this now. I'm like, let me control this patient's pain and likely catecholamine surge secondary to the pain they're experiencing. But I think the juicy part is really in the physical exam, and would love to hear Robbie's discussion of it.
Well, Prof. Rez, I definitely think we should tag team it. I'll share my instinct, but I'm not very confident on it. So I'd be really curious what yours is. And mine was that it's interesting that there's such a profound disconnect between the arms and the legs. And that had me wonder whether that disconnect means there's something unique to the arms and not the legs, which if I use your very well-distilled model of peripheral nerve or central nervous system and just keep it that 10,000 foot view, I think it's hard to imagine the central nervous system would somehow just selectively target both arms with sparing of the legs. So as soon as I heard that, I was like, oh man, it must be like the nerves, and wondered if the patient has bilateral brachial plexus injuries as a simple way to sort of unite everything. But then when we heard that his post-void residual was 1 liter, that pushed me back into the central nervous system. And since the central nervous system, I think, is much more morbid in its ability to destroy more things, if in fact it is the peripheral nervous system, it's bilateral brachial injury or nerve injury, there's not much risk for additional injury. In stark contrast, if it is the central nervous system, then the patient's at risk of compromising more than just his arms. So the question that I was asking myself is, how could somebody have just arms in the cervical spine, both arms and nothing else? And I think this is a great reminder from the sort of subtleties of anatomy that I'm not confident about. But if I remember correctly, the leg innervation goes out more peripherally, and the arms are more centrally. So if a patient has a lesion in the middle of their cord, it might involve both arms with sparing of the legs. And honestly, the only reason I remember it is because first aid in step 1 reminded me that patients with syringomyelia have a cape-like distribution of their weakness, as if they're wearing a cape. And so that's the only neuron that I have left from those days. I haven't thought about it since then. So for me, I have to acknowledge that this is not something I've ever seen before. So I'm walking on territory that's built from knowledge that is ancient. But I think the things I do know now are, if you can't tell if it's central nervous system or peripheral nervous system, prioritize the central nervous system. And as Prof. Rez said from a long time ago, whenever you have bowel and bladder dysfunction, that is so specific to the central nervous system that supersedes anything else. So if I try to make a prediction far beyond my comfort zone, I worry this patient has something in his central cord in the cervical spine, but that would tear my pants in real life. What would I be able to confidently know is, I think there's too much morbidity to skip over imaging. And I think if I could get one piece of imaging, it would be an MRI of the cervical spine. Where did it land for you, Prof. Rez? How did you analyze it?
Oh my God, like I have zero to add. Like that was just so well said. I think your final sentence really captured it all, saying that if you can't tell for sure, given the morbidity and irreversibility of central nervous system pathology, you have to rule it out. You really do. And just knowing that we're all human beings, and like, am I going to rely on my ability to check for it, the motor exam to perfection, the reflexes to like, I'm totally fine with this being completely normal reflexes, and then we scan them and something really abnormal is in the central nervous system. It just comes down to bladder and weakness. You have to run towards the central nervous system. Almost like, what you said, Robbie, like, even if you diagnose 5 PEs out of 100, you've done your job correctly, because it's that morbid. Same thing with ACS, same thing with spinal cord injury. Oh, and one last thing, I'm so grateful for that one neuron you had of the syringomyelia and the cape-like distribution. May you not, that neuron is going to be very strengthened after this case, if it ends up being syringomyelia.
Indeed, Prof. Rez. It's strengthened already by your humor, no matter what the DX is. Mike, to you, Hans.
Okay, then I continue with the lab values. And as you anticipate, imaging was done immediately. So lab values, most of you probably guessed it, CBC was normal and chemistry was unremarkable. That's all the labs there are. Imaging was immediately proceeded with an X-ray of the cervical and lumbar spine, and no fractures were seen there. So the next step in imaging, and it actually brings us very close to the diagnosis, was an MRI of the cervical and thoracic spine. And I'll just give the official read. We have found an epidural, possibly subdural lesion from C7 to T5 with high intrinsic cord signal change at C2 and C6. The radiologist mentioned the concern for hematoma compressing the spinal nerve tracts. Further findings, as we looked at the upper chest, a conglomerated lymph node in the left neck at level 3 and 4, and a subclavicular lymph node
Oh, no, I think we lost you, Hans, after you said subclavicular. Maybe you can try again, or we can start to work with what you have already.
Uh,
Unfortunately, it's still a little bit choppy. Oh, yeah, I think, um, Hans, maybe we can try to analyze this because I think it's plenty to work with, and we'll see what you have in store. And I think, yeah, Prabhat, I'll pass the mic to you to analyze the MRI. I just want to highlight why I think it was really important to get blood work in this patient, and I still think that you might even consider getting more blood work. And this is the argument that I'll make, which is that it's really all in that vulnerability space, and the open layer of vulnerability that I'm wondering now that we're hearing that the patient has some epidural hematoma. Pass the mic for Prof. to analyze. But now I think the question in terms of the blood work is there a reason beyond the trauma that this patient developed this complication? And I think we have the hematology, the CBC, and the chemistry. I'm still curious if his coags are perturbed in some way, shape, or form. But I think that's a small question. I think the biggest question is the MRI. I'll pass the mic to you, Prof. Red.
Yeah, that's great, Robbie. And I guess like when I just think about this case in retrospect, trauma, bleeding, it's a really good fit. I will say that like I'm sort of reliant on the radiologist here. I think that whenever you have a neurologic presentation and you get imaging, your question should be, is the imaging explanatory of the neurologic syndrome? Because a lot of times you'll find stuff on imaging that is just an incidental finding or radiographic finding. But I think here, Robbie and I have emphasized, like we were most interested in the cervical spine. So I personally think this is a great match for this patient's clinical presentation. And maybe, Robbie, what you were saying with regard to the arms versus the legs, who knows neuroanatomically why it manifested as such. But I'm fine with saying this is the reason the patient presented as they did. Now the question becomes, the radiologists are pretty good at detecting blood. Like, I don't think there's going to be a question, is this cancer? Is this infection? Is this, no, because like the Hounsfield units and how they assess it with gadolinium, they're probably quite convinced. The question I think Robbie and I have to answer is, what do we do about the lymph nodes? And is there a bleeding diathesis? I think that honestly, like my reflex of the lymph nodes is that they're just, you just had trauma. You have a lot of blood there and they're going to try to drain it. And I wouldn't really focus on the lymph nodes. I think personally, it would be a mistake if you're solving a case for epidural hematoma and then implicating, a lymphoma. There are cases where you can have a hematoma and you can have liquid malignancies like myeloma that are angioinvasive and lead to a bleed. But in this case, Robbie, I'm not really too focused. I know like subclavicular is a red flag and whatever, but I'm just so fine with everything happening here explaining the lymph nodes. And I think the question just becomes twofold. Was the trauma itself enough to cause this bleed? I think it probably was, but you got to look for bleeding diathesis. And then two, how do you solve and prevent further neurologic damage? I can't answer that question. I think you need a neurosurgeon, someone who's seen thousands of these types of cases, to decide, like, can we remove the blood, or is the blood tamponading off the bleeding vessel and we don't want to remove it? Do we need to get IR involved? Do we need neuro IR? I'm not sure. But I'd love to pass the mic to you, Robbie, for your thoughts on that sort of overview of this aliquot.
It's perfect, man. I couldn't agree more with you. I'm itching to do something because I can't shake these itches pretending that this patient is mine. And I just want all of us to imagine how difficult it would be to relay to the physician taking care of you what you were like before you fell. Because what happened was you fell, you've had a really hard fall, and now you're on the verge of being paralyzed from it. Who cares if you were having fevers, chills, night sweats, weight loss before that? You're not going to think to bring that up. And so I think this is why it's so important to have that 3C framework for connecting two things. Is it causal? Is it contributory? Or is it coincidental? And I think, Prof. Rez, we're now asking ourselves, are these lymph nodes contributor, or are they completely unrelated? And I think if he tells us I was completely fine before this fall, then it becomes almost implausible that he has anything else but the reactive lymphadenopathy to the horrible trauma that he had. But if we later learn after he's stabilized that actually he's had fevers, chills, night sweats, weight loss, then lymphadenopathy in a young boy like this could mean many things, especially lymphoma, so on and so forth. So always be very careful about connecting as a causal relationship, a trauma, an event. And I think now you want to rewind the clock and be like, well, okay, I'm sorry you fell. What happened 3 weeks ago or 1 month ago? And I think that'll be our most powerful clue. Not so much how big the lymph nodes are, so on and so forth. It's always on history. So is there no history for these lymph nodes? Or is it hidden behind a very massive event that has caused a lot of trouble?
Dude, that is such an epic point. I'm just recently had a case where someone was having symptoms that ordinarily would serve as an anchor point for a discussant, but they had other symptoms that trumped that symptom. So they didn't bring it up until after the fact. I'm being a little vague here because I may present it to you.
Ooh.
But I just want to hammer that point home for the audience. This is not just like a VMR teaching point. It's reality. Like when you have like a devastating fall, all of a sudden what preceded that is probably not going to be very important. So thank you for making that teaching point.
Prophet, you're so good at saying what I said so much more concisely, accurately, and engaging. I should just talk and then trust that you'll say it a whole lot better. Thank you. That was awesome. All right, well, Mike, to you on.
Okay, my apologies again for the internet. Because of the severe symptoms, neurosurgery was consulted to decompress the spinal cord. And the surgeon, during surgery, they found, that was quite a surprise, an intradural extramedullary mass. The diagnosis was then later presented by the pathologist. Histopathology reported a malignancy with the finding of anaplastic large cell lymphoma, an ALCL. This lymphoma was later found to be ALK positive, which is treatable. And the patient then received chemotherapy and he's doing fine. His paralysis and numbness disappeared. And that's as far as I know. So the diagnosis in the end was a central cord syndrome, of which I've not heard by until then, secondary to a lymphoma, the ALCL, aplastic large cell lymphoma. Thank you very much for the opportunity to present a case that was a bit surprising even for me.
Hans, first of all, you're just incredible. Like I said, I've seen your name so many times in the chat. So I feel like so happy to be able to discuss with you on this VMR. So thank you so much. Prior to the neurosurgeons going in, were you or the neurosurgeons concerned for a lymphoma, or was that truly like a surprise for all of you?
The lymph nodes are somehow a little bit unusual. So you don't know what's happening there. It could be reactive from the fall, as you discussed, or it could be something else. But it was a surprise because I actually expected some blood compressing the spinal cord, and then by decompressing it, we would have given the patient great relief, but that wasn't the case. It was something else.
And one more question for you before I pass the mic to Robbie. Did he have any preceding symptoms before this fall?
Actually, nothing major was mom didn't mention anything, the child didn't mention anything. So to find any connections between before and afterwards, I don't
So
think
how lucky was he having that fall? Back to that point, like that was probably the best bike accident anyone could wish for. Unlike when you and I fall, Hans, we just fracture stuff. This guy gets, that's incredible. All right, Mike, to you.
No, Professor, I love this conversation because I think it goes back to like if we were to do a cognitive autopsy of the connection between trauma and event, I think completely causal is removed because there's no way that a fall can create a lymphoma in your epidural space, right? So now you're left with, is it a pure coincidence? Or did it contribute in some way, shape, or form? And that is purely speculative, right? So either he experienced a very profound, real human event called recall bias, which is why everybody blames Chipotle for their diarrhea. Prof. Raz will tell you it's unreal. It's never the case. Chipotle does not cause diarrhea. Or that he bled a little bit after. And gosh, where are you? If you fall and hurt yourself, who's more likely to bleed? Somebody with or without lymphoma? Definitely. The fragile blood vessels in any cancer causes many cancers to bleed. And we talk about this a lot in the brain. You know, if you have a brain tumor and you fall, you hit your head, or you're getting a scan no matter what. Why is it different in the spinal cord? I don't see why it would be. So guys, as Simi just emphasized, our newest sponsors are Dunkin' Donuts and Chipotle. Thank you for this amazing episode. But Prof. Rez, final reflections to you, and then we can hear from Gerardo.
Honestly, I think it was such a phenomenal case presentation, and I just really grateful that Hans, during your break between patients, you would present. You're a legend, man.
I think Hans is typing in the chat ferociously. So Mike, to you, Gerardo, for the teaching point.
Oh, yes, thank you so much. So, I apologize in advance because I had a really bad trouble with connection, but I've been able to capture most of the discussion that you guys had. And I think this was a very interesting pediatric case and the analysis began with the problem with progressive bilateral arm pain, weakness, and numbness, which are three chief complaints that we had a little bit of trouble deciding where we would start. But I think weakness was a very good point to start because we have a very determined framework to assess it, right? So first in weakness, we have to determine if there is a really decreased muscle power or the sensation of weakness, which is subjective weakness. And also it is important to the localization, and obviously there are a lot of structures that can cause weakness, but if we break it down between two variables, the CNS and PNS involvement, that could be an easier way to assess it, right? So when we have a CNS injury, we suspect or we are expecting to see a sensory level bowel and bladder symptoms like this patient had, or hyperreflexia, which are signs of upper motor neuron and damage, or versus the PNS damage, which is the lower motor neuron that would manifest with atrophy and fasciculations. And also the fact that this patient had bladder symptoms and bilateral upper limb weakness prompt us to ask for cervical spine imaging. But before the imaging, there were key aspects of the neurological exam that we were analyzing that. And I think the most important one was the disconnection between the findings of the upper limbs versus the lower limbs. And also one differential diagnosis that we considered and also was mentioned in the chat was syringomyelia, which can arise from trauma or from congenital abnormalities like Chiari-1 malformation. And it can present with a suspended decrease in temperature and pain sensation. And that is because the central cord is affected, and in the anterior white commissure where the spinothalamic fascicles run through, the syringlomelia compresses it, and that can cause suspended decrease in sensation. And also, if it expands more, it can also cause weakness because it affects the anterior horns. But that wasn't the case. But I think it was a really a step one interesting fact to discuss. And also, the lymph node involvement, we were having trouble deciding if the lymph nodes are reactive from the trauma or are related to another disease process that isn't linked to the actual presentation. But it turns out that the patient finally was found to have an epidural hematoma, and that epidural hematoma was caused by a mass that was a lymphoma that prompted, and the fall basically prompted the assessment of the patient and the surgical visualization of the mass that was found gave us the final diagnosis, which was completely unrelated to the trauma, but the trauma prompted us to the diagnosis. So this was a really interesting case. I haven't seen something like this before, and yeah, I'm very thankful for this space.
How lucky are we to have a soon-to-be neurologist to bump into this case? Gerardo, you rehashed what we taught and added your own astute wisdom. Very, very grateful. Hans, Reza and I were chatting about how lucky we feel to have you in our orbit. Really, really thank you so much for a wonderful case. And Jillian, 2 out of 2 scribing. Today was a little bit less exhausting than yesterday, which I'm very, very happy to see. Have a great day, everybody. See y'all later.